Hello, and thank you for the opportunity to present these results in terms of response to apalutamide among patients with non-metastatic castration-resistant prostate cancer from SPARTAN using DECIPHER Genomic Classifier score. So these are the disclosures for myself and my co-authors. In terms of background, very briefly, patients with non-metastatic castration-resistant prostate cancer, or nmCRPC, with a PSA doubling time of less than or equal to 10 months are at higher risk for metastases or death than patients with longer PSA doubling times. AR receptor inhibitors such as apalutamide, enzalutamide, or darolutamide added to ADT improve outcomes in these high-risk non-metastatic CRPC patients. The DECIPHER score, well known as a 22-marker mRNA-based genomic classifier, can support treatment decisions in patients with localized disease and predict disease progression in newly diagnosed patients, as shown here, where clearly the GC score based on DECIPHER helps to predict patients at low, intermediate, or high risk of metastases in patients diagnosed with localized disease. We decided to look at whether this DECIPHER GC score could be helpful in predicting outcome in patients with non-metastatic CRPC with or without apalutamide treatment. So SPARTAN, just briefly, was a randomized phase 3 placebo-controlled study in patients with high-risk nmCRPC, published in New England Journal last year. Patients had doubling times of less than 10 months, randomized 2-to-1 between apalutamide or placebo, and the primary endpoint was metastasis-free survival, and patients went on to subsequent treatment based on clinician discretion. The results showed a very impressive 2-year delay in metastasis-free survival in patients on apalutamide versus those that started on placebo in this study. We had pre-planned and exploratory biomarker analysis in SPARTAN using archival tumor collection that was voluntary, and we had 340 cases on which to evaluate DECIPHER human exon array. Unfortunately, 107 didn't reach quality control, so we were left with 233 patients that had DECIPHER scores of less than or equal to 0.6 or above 0.6, which stratified patients into high risk with greater than 0.6 or low to moderate risk with less than or equal to 0.6. It was nicely separated that 50% of patients had high risk and 50% had low to average risk. And we looked at the association between the DECIPHER GC scores and MFS using Cox proportional hazards model. Here are the results. Regardless of DECIPHER GC scores, all patients had statistically improved metastasis-free survival using apalutamide compared to placebo. And when we observe patients with low to average scores, we see that apalutamide improved the outcome, going from 22 months in placebo to unreached in patients on apalutamide. And in the high scores, placebo developed metastases within 14.5 months, and again, not reached in patients on apalutamide. If we look at specifically the outcomes of patients based on their scores, we see that the placebo patients, patients with high scores developed metastases really quite early, 14.5 months, which was statistically significantly earlier than patients with low average scores. However, patients on apalutamide, it made no difference whether they were low, average, or high in terms of time to metastases when they were treated with apalutamide. So in conclusion, regardless of DECIPHER GC scores, all patients had significantly prolonged MFS following the addition of apalutamide to ongoing ADT. Patients with non-metastatic CRPC with high GC scores are really the highest risk population of developing early metastases with ADT alone. And this is quite striking that we're able to determine this as early as the diagnosis of these patients when they were still localized disease. Despite the high risk of early progression in patients with high GC scores, the addition of apalutamide to ADT was as effective in this subgroup as in the patients with low to average GC subgroups. I think this justifies the early treatment intensification in patients with apalutamide in especially the high-risk GC subgroup, since they were significantly improved in terms of MFS, and this clearly fulfills an unmet need in this very high-risk population.